Good afternoon, everyone. Welcome to the Clinical Trials Methodology course webinar series. Today's webinar is focusing on rare disease trials. Before I introduce our presenter, I'd like to remind you to stay muted during the presentation unless you have a question. You can simply unmute yourself to ask a question, or you can type your question in the chat box, and I'll be keeping an eye on that for you. Also, at the end of the webinar today, please take a moment to evaluate the webinar. The link is will be in the chat box shortly. And also our next webinar is on good clinical practice and will be held on September 10th at noon Eastern. So keep an eye out for that in September. So now I'd like to introduce our presenter today. Today's presenter is Melanie Quintana. She's Dr. Quintana is a statistical scientist at Berry Consultants, LLC. Her research interests include Bayesian model uncertainty and prior specification with applications to genetic association studies. She has a PhD in statistics from Duke University, and she's been part of our faculty in the past years with the CTMC. So I'd like to thank her for her time and presentation today. And I will hand it over to her.
Great. Good afternoon, everyone. So as Joy mentioned, we're going to be talking today about rare disease and designing clinical trials in rare disease. I thought the best way to do that would be to just go through two case studies of trials that we've designed in the rare disease setting, and then try to generalize to see lessons learned and highlight sort of good practices in designing clinical trials for rare disease. As Joy mentioned, if you have any questions throughout, please feel free to ask them to stop me. We can make this as interactive as you would like, and I'll do my best to answer those. So the first case study that I want to talk about today is that in a disease area known as dominantly inherited Alzheimer's. So I'm sure you all are familiar with Alzheimer's disease. Dominantly inherited Alzheimer's is a rare genetic form of Alzheimer's. This occurs in less than 1% of the total Alzheimer's population. It's due to a known genetic mutation or several known genetic mutations. If you have one of those, if an individual has one of those mutations, they will develop Alzheimer's, and likely at a very early age of onset, between 30 to 50 years old, similar to when their parent who also had the mutation started to develop clinical symptoms or cognitive symptoms. In the Alzheimer's space, if you're not familiar with this space, there's been a lot of investment in terms of trying to find a therapy that alters disease progression, and we've really mostly been quite disappointed in what has come out of that. It's thought now that the issue with clinical trials designed in Alzheimer's was that we were treating individuals too late. So we were treating individuals more in this mild cognitive impairment or dementia state. And that was simply because we wanted to enroll a more homogeneous patient population that we knew would certainly progress in terms of key clinical endpoints, in this case, the cognitive function. So now it's thought that we need to be able to treat individuals earlier for our therapies to be effective in modifying disease progression. However, the issue with that is if we're treating individuals earlier, if we treat them too early, they would not be expected to progress over the course of the trial. So we really would not have any power to differentiate between, a complete cure and the placebo group. So really the goal in Alzheimer's in general is to be able to enroll individuals in this preclinical space, but those who are likely to progress over the course of the trial, so that we can differentiate between an effective therapy and the placebo group. In dominantly inherited Alzheimer's, we have the rare opportunity to do this because we know these individuals will develop Alzheimer's, and we have a good estimate of when they will start developing cognitive symptoms. So we'll talk more, and I'll go into more details throughout this talk on exactly how we do that, and we use that opportunity. The other case study I want to talk to you about today is also a rare progressive disease. This disease is called GNA Myopathy. This disease is categorized by slow progressive muscle weakness and atrophy. It's thought to be due to a lack of production of sialic acid. So the individual's muscles actually atrophy and begin turning into fat. At different stages of the disease, different muscle groups are affected. It kind of starts at the ankles, works its way up, and also in the upper extremities sort of works its way in towards the body. You can see individuals here, different MRIs. Here, you would have to look very closely, but essentially this individual has all of their muscle strength on most of their main muscles in their lower extremities, in their hips. However, their ankles muscles are starting to, dorsiflexion are starting to turn into fat. If you look at someone almost completely progressed, very little muscle in their lower extremities. So the goal here in GNA myopathy, as well as was dominantly inherited Alzheimer's, is to develop a clinical trial, to understand if a treatment slows the decline of muscle strength, modifies disease progression in terms of muscle strength. In both of these cases, we can sort of quickly diagnose and see what the complexities are in designing trials for rare progressive diseases. The main issue here is the heterogeneity in progression, whether that's when a person progresses, how quickly they progress, what muscle they are actively progressing on in terms of GNA myopathy. And what that leads to in terms of clinical trial design is large variability in the key clinical endpoints. So lots of variability in the endpoints that we want to study to try to discern if the treatment is different than the placebo group. Of course, common solutions in the non-rare disease setting are we enroll a more homogeneous subset, as I mentioned was done in regular Alzheimer's or sporadic Alzheimer's trials, or enroll a large enough sample size to overcome this heterogeneity. Obviously, these are not tools or not solutions that we can use in the rare disease setting. The first, because we don't want to make a rare disease even more rare by only allowing a very narrow subset of the individuals to enroll in the trial. And the second, because oftentimes we don't have a large enough sample size available to enroll to overcome the heterogeneity. So I'm going to focus on going through these two examples in details, walking you through exactly what we did when designing these trials, how we overcame sort of those complexities and those limitations. But a brief overview for each of these is in both genetic GNA myopathy and Diane, we were very blessed to have natural history studies or observational studies that provided us with rich data on how individuals progress under natural history in terms of key clinical endpoints. So how individuals progressed cognitively in the dominantly inherited Alzheimer's group, and how individuals progressed on the key clinical muscle groups under natural progression. This allowed us to essentially just know what we're working with, which is one of the key takeaways here that I want to spell out and make very clear is that, especially in rare disease, where we can't just enroll a big enough sample size and hope that we can discern a difference between treatment and control, we really need to understand the endpoints that we're working with. And we really need to have realistic approximations for the power of our designs that we are proposing. Natural history studies are one of the best ways to do this, and oftentimes we are blessed in rare disease that natural history studies have been run. The other aspect of this that I want to describe is more innovative designs or analysis methods. So especially in rare disease, we want to be able to make use of all available data as best as we can. In terms of GNA myopathy and Diane, or dominantly inherited Alzheimer's network, this comes about by using the longitudinal data, sort of repeated measures or the disease progression of the individuals, and using all of that information to discern if a treatment is different than the placebo group. You'll also see that we can get some power gains, and there's advantages to doing sort of adaptive designs where we have more frequent interims to discern if we have reached early success, and able to, because the treatment is so effective, enroll a smaller sample size. And also using all available data that we have, not just sort of repeated measures, but also using potentially using the natural history data as a comparator to the treated individual. So now I want to dive sort of into more details, first of the dominantly inherited Alzheimer's network and the designing of that trial, and then we'll talk more about GNA myopathy. So as I mentioned, the first step, I think, in designing a trial in rare disease is always just to understand what you're working with. Understand truly how the endpoints that you're going to use in your clinical trial, how they act over time, what's their variability, what's their average rate of progression if it's a progressive disease. So in the Diane network, we were blessed, as I mentioned, with this nice natural history data set. Here, what I've plotted is the cognitive composite score. This is a measure of cognitive progression. It's essentially a few cognitive tests, standardized and then averaged. On the y-axis is what we call EYO. This is expected years to onset. And this is based on the participant's specific mutation type, as well as when their parent developed cognitive symptoms. The red dots here and the red lines are individuals who are mutation carriers. These are individuals who do have dominantly inherited Alzheimer's. The blacks are non-carriers, so individuals who do not have the mutation. So what you can see here is sort of some just random noise about healthy, right at 0, and 0 here would indicate you're healthy on this measure. However, this steep sort of waterfall decline or waterfall effect, once you reach EYO about around 0. People tend to be healthy for a long period of time on this cognitive composite, and then this sort of steep drop-off. So our next goal is, given this data, we want to take this data and summarize it in some way. What's the average rate of decline as a function of EYO? What's the variability of this measure just at normal or at healthy? What's the variability of the decline? Some way to sort of summarize this data so we can then use those summaries to understand power of a clinical trial design using this endpoint. So how we do that in progressive diseases is what we can call a disease progression model. And really, at its most simple form, this is any model. Think of it could just be a linear regression that summarizes how the disease endpoint will progress over time. Time here could be chronological age. If it progresses similarly across all individuals as a function of age, it could be years since onset. Some individuals may have different time of onset, so that could be years since onset. Or what you'll see in the GNA myopathy case is it could be this sort of latent variable that we call disease stage or disease age that is not measured, not observed, but can be estimated from the data. But essentially, these disease progression models, as I'm calling them, are just a model of how these clinical endpoints, the ones that you'll want to study in your trial, will progress over time. This is a lot of math and a lot of statistics on this slide. I'll try to explain it quite simply so that you can understand how we summarize the Diane data using a disease progression model. But essentially, all this is just a non-parametric curve. At each EYO bucket, say from 0 to 1 year, we estimate a decline. And we do that for all buckets. And we induce some sort of smoothing. So this is a smoothing spline you can think of across the EYO. We do add 2 other additional parameters. One is that what we call a random effect for the adjustment in the estimated age of onset. So this is an adjustment to move individuals left and right on the x-axis. So everybody has an expected years to onset. That's based on their mutation type. A priori, that is where we think or when we think you will start to decline. However, the data may say or tell us differently and help us estimate that, no, we actually believe based on this individual's data that they're about 5 years to onset, not 4. Or they are 2 years past onset, not 5 years before. We can estimate this through the model. We also have another random effect in the Y space just to measure that some individuals are healthier than others on average, or some just perform better on these tests than others. What does this look like in terms of the actual data? Well, here is those same red dots that I showed you before. If we subtract off what I'm calling random effects, those random effects, we get this sort of data. So we're subtracting off the Y-space random effects, sort of shrinking these subjects in towards each other, and subtracting off the estimated random effects in the X-space. So we get a much cleaner picture of progression when we do that, and then we can estimate sort of on average what we believe the individuals, how they will progress over time as a function of their expected years to onset. We can also estimate the variability around this. We can estimate the variability of these random effects on each the y-axis and the x-axis, and we can have good summaries for all of these things. So the key question then is, step here for a second. Wait 1 second. The slide is not advancing. Are you guys seeing the plots?
Yes, the DIAN disease progression, the plots with the red.
Yeah.
Oh, there it is. Okay. But it's not in slideshow mode.
Okay, so the reason that we want to create these summaries of natural progression or summaries of the endpoints that you want to use in your clinical trial is to understand power. That's the main reason, power of your proposed design. And how we do this in a more complex setting when we don't just have, very simple summaries of the data saying, oh, the change from baseline is going to be X on average and the standard deviation is going to be Y. When it's a little bit more complex, the endpoint, when we think it changes in a nonlinear fashion, we'll want to use some sort of virtual patient simulator. So we can take our natural history study, we can use some sort of model to summarize it, as we did, and then we can use the same model to actually simulate patient-level data, realistic patient-level data from that model. So we simulate a patient, we simulate what their data would look like, for instance, cognitive decline over the course of the trial, and we do this for every individual who would enter the trial. We actually run a simulated clinical trial based on your proposed design. What's the sample size? What's our analysis method? How long do we follow them? We do this thousands of times, and we get an estimate of the power of the trial. This is clinical trial simulation, and I'm sure you'll hear a little bit more about this in other either webinars or in your course as well. But the whole point of getting a good summary of the natural history study is to be able to create this realistic virtual patient-level simulator. So actually, in theory, this is a harder concept to understand, so I'll show you exactly what this might look like. So here's that curve that we calculated. Cognitive score, expected rate of progression as a function of a subject's year since onset. This is that plot. Again, I've just squished it down to show you some simulated data. Here is that plot, average decline. We know there's variability around this in terms of the y-space. We also know that there's variability of people entering at different years since onset. So let's say we want to simulate one subject. So this first subject comes in. We simulate that their random effect in the y-space is minus 0.8, given the variability that we estimated from our model. So this subject, on average, performs a little bit worse than most individuals on this test. So we expect they're going to follow this black dotted line over the course of their disease if they were not given any treatment. We enroll them in the trial at 5 years since onset, 5 years after they had their cognitive onset. So we enroll them at this point. So they would follow this black dotted curve if they were on placebo. We can also put in some sort of treatment effect. So we can say, okay, what if they were given a treatment? What if that treatment slows progression by X%? Well, then if they were a treated subject, we think they would follow this blue dotted line. So what do? We simulate data given our estimates of variability around this blue dotted line. And this is what you would actually see for this subject. If we're talking about a 4-year trial, this is the data that you would actually see from this subject. We can do this again for, say, a placebo subject. So this subject comes in, they're about 4 years from onset. They're also a little worse than average on how they're performing on this test. We think that they'll follow around this curve with some variability. This is what their data looks like. And what do we actually get to observe in the trial? Well, the years since baseline, this is how their data looked from year 0 to 4. You can do this over and over again. The blue are treated, the black are placebos. You can see the data itself is quite messy, but when we start looking at the means for the blues versus the black of the cognitive score at each time point, you can start to see that the blues progress a little bit less than the blacks. On average, at 4 years since baseline, they progress about 1 point, whereas the blacks -2. And you can see that that trends backwards as well. We see this sort of gap from 2.5 years on of a difference in the where a subject has progressed. So this is what an actual virtual patient simulator looks like. Now what we would do is say propose, this was just with 10 subjects, we could say propose to do this on 50 subjects, simulate 50 subjects, this is their data, and then we would have to pre-specify an analysis plan. So if we had, say, just change from baseline at 4 years, we would get a p-value from this data, and we would say, okay, was this trial successful given this observed data? Yes or no? If we do this thousands of times, we can then get an estimate of power, the proportion of trials that were successful given the treatment effect that we assumed and given the design that we specified. This is how we simulate power under the proposed endpoint using realistic patient-level simulator. So as I mentioned, we use this to understand power. The initial proposed design for the Diane study was 80 subjects per arm, randomized 3-to-1 treatment to control. The max length of follow-up was going to be 4 years, and the primary analysis method was a traditional analysis method for repeated measures at MMRM. And this is just a repeated measures model, essentially. And what we saw when we did these very realistic patient-level simulations, we did all of this work to understand natural progression in terms of our key clinical endpoints, but the treatment effect that we're targeting, around 30% reduction in decline, we had power less than 20%. So great, we did all of this work, and now what we're seeing is that we're majorly underpowered for our proposed design. But that's okay, at least we know that going in so that we can try to do things, have modifications to our proposed design to get more power out of what we're proposing. So the first thing that we looked at was the analysis method. So the repeated measure models that people typically use for longitudinal data has some known issues. The first is the dilution of any sort of treatment effect due to subjects not expected to progress. So if we go back here, if we enroll some individuals on this part of the curve, they would not be expected to progress under placebo and not expected to progress under any sort of treatment effect. So the change from baseline, essentially between the blues and the blacks, if we enrolled everybody here, would be 0. There would be no way to differentiate. So if we enroll some people in this space, they'll dilute any sort of change from baseline effect. If we don't adjust for the fact that we know that they were not expected to decline. The other issue is that the MMRM essentially just tests the change from baseline at a given time point. It tests at 4 years what is the difference between the treatment and the group. Not using the fact that we're also seeing a gap at 3.5, 3, 2.5. So it's not using the repeated measures or the longitudinal data as well as it possibly could. So instead, what we did was look and develop a different analysis method. to be able to, A, adjust for the fact that we have an expected years to onset, adjust for the fact that we know some people wouldn't expect progress very much over the course of the trial, given where they start the trial, and B, to introduce a treatment effect that is a proportional slowing in the disease that uses all data. So it takes the difference you see between treatment and placebo at 1 year, as well as 2, 3, 4, 5, 6, to estimate the treatment effect, similar to how you would do in sort of a time to event analysis. All sort of patient exposure, and the more exposure you have, the better power you would have with this type of analysis. So essentially what this analysis does is if we're treating an individual here, it knows and adjusts for the fact that the magnitude of the difference between, say, the black, which is placebo, and, say, the green, which is a 50% slowing in progression, is going to be very small for this type of patient. You don't expect there to be a big difference. However, if you were enrolled here, we expect there to be a large magnitude difference between the black and the green. And this patient would be weighted more and almost count more to the analysis than this one over here. And as I mentioned, we are using this analysis, we're able to incorporate different lengths of follow-up due to missing data or early interim analysis. We also can incorporate extended follow-up. Often in rare disease, we try to use all available data possible. So these trials can be slow to enroll. So what that means is you have the potential to follow the first patient enrolled for longer than the last patient enrolled. So say the first patient was enrolled and it took over a year to enroll this trial. We could keep following them until the last patient enrolled was followed for 4 years. So you might have 5.5, 6 years of follow-up on the people who were enrolled earlier on, and this analysis uses that extended follow-up data. And again, like sort of a time to event analysis, the more exposure you have, the greater power you have. And for those clinicians who are listening, don't get too caught up on the actual details of the analysis method that we chose. I'll show some references at the end if you want to read about it a little bit more, but just try to get the overall picture here that there are better, or not necessarily better, but other analysis methods that could be used, especially in these rare disease settings, more innovative analysis method than just a change from baseline. Get more power out of your data. So just changing the analysis method, we were able to go from less than 20% power to over 60% power. So a substantial increase in power. What took us the rest of the way is, as I mentioned before I started, this is a platform trial. So what is a platform trial? The Diane trial is sort of, think of this as a standing arena where multiple drugs come in and are tested to be effective in dominantly inherited. So when this trial started, it started back in 2012, this standing sort of arena, and we were actually enrolling 2 separate drugs within the same trial. So think of multiple drugs, very similar indication. So each drug was enrolling 60 treated and 20 placebo, 80 total, 3-to-1 randomization. So what we're able to do is, because these are enrolling both within the same trial, we have 20 placebo patients from drug A, 20 placebo patients from drug B. We actually share the placebo patients. So for any analysis on drug A, we use the placebos from drug A as well as the placebos from drug B. So this is the spirit of using all available data, using placebo data from other trials. In this case, it was within the same trial, but another drug. Also, I should mention that we had adaptive interim analyses, so frequent interim analyses to stop for early success of futility when all subjects were followed for 2, 3, or up to 4 years. And so what this design did, in just the fact that we were able to share the placebo subjects, we're able to take our power from, again, where we started less than 20% to above 80%, almost 90% power. And again, this is just from sharing placebo subjects from the 2 sort of quote-unquote trials, as well as a more innovative analysis method. And also because we had more frequent interim analyses, the probability that we stop this trial early, not having to follow everyone for 4 years, was raised. So we actually had less than a little bit above 35% probability that the trial could be stopped for success at 2 years of follow-up, about 70% probability we could stop this at 3 years, and then that 90% power at least 4 years. So we have a good amount of probability that we could actually stop this trial a year or two early, which is especially important in sort of a rare disease setting and an unmet medical need where no current treatments exist. So in summary, for the Diane trial, I would say, it's very important, as I mentioned at the start, to understand what we're working with. And in doing so, we learned that the original power for our plan design was less than 20%. So we went back to the drawing board, we came up with better analysis methods, we used all available data, and we were able to increase our power from less than 20% to greater than 80%. The key here is know that we were in this underpowered situation from the start. And you'll see next a similar story for GNA myopathy. But I'll pause for a second before I go into the GNA myopathy and see if anybody has questions under the Diane case study. Sort of just unmute yourself and ask them, or type them into the chat box. Okay, so any questions in the chat box, Joy?
No, I'll clear.
Okay. Okay, sounds good. So we will go into the next example, and I think what you'll see here is a very similar story. I went with the Diane story first because that's almost a more simple picture. We're just talking about one endpoint there. It was this cognitive composite endpoint. Now in GNA myopathy, it gets a bit more complex because we're talking about multiple endpoints. We're talking about multiple key muscle groups, understanding how those move over time, understanding how those will act in terms of an endpoint in the clinical trial that you're proposing, and figuring out how we induce sort of a quantification of how treatment slows the rate of progression across multiple measures. So it's a bit more complicated, but I think you'll see a very similar story unfold. So in the GNA myopathy, again, as I mentioned with Diane, we were blessed with this really nice, rich natural history data set. At the time of this slide, I think we had about 38 participants. They were doing visits every 3 to 6 months. We were getting up to 3, 4, 5 years of follow-up for these individuals, and we were collecting a lot of possible primary endpoints. The traditional endpoint in sort of muscle degenerative diseases is 6-minute walk test. This is essentially how far can you walk in 6 minutes. The other endpoint that we were collecting is called a quantitative muscle assessment score, and this is a assessment of essentially how much strength you exude for that muscle group when you do a test, and I'll show you a picture of this in a second. But we do this for multiple muscle groups. Here's a picture of someone actually doing this QMA. I think here they're getting the strength for their quadriceps, actually. And this is what some of this data looks like for the QMA. We can get for each side sort of left and right grip, their measured strength in kilograms, but then we can convert that to percent predicted. So convert that to a scale of almost percent of healthy. Percent predicted is the percentage of what you scored relative to what an individual who is healthy would score of the same age, gender, and BMI. We can get this for a lot of muscle groups, as I said, grip, wrist extension, shoulder abduction, elbow flexion, elbow extension. Those are sort of the upper extremities. And then we have the lower, dorsiflexion, the ankle, hip abduction, hip extension. knee extension, and knee flexion. And so you can see for this individual, they're performing quite well on grip and wrist extension, a little bit worse on elbow flexion and elbow extension, and then not very well, almost a quarter of the expected percent strength that a normal healthy person would have for their ankle dorsiflexion, and for their knee extension also progressed quite a bit at this point in time. So this is what the data based on QMA actually looks like for an individual. Let me get back there. Sorry about that. Okay. So we have multiple, as I mentioned, in this natural history study, we're collecting lots of different endpoints. So we can take that data. This is actually what it looked like for individuals in the natural history study for, say, 6-minute walk test. How many meters can you walk in 6 minutes? So what you can see here in terms of this endpoint is lots of variability at baseline and very little progression across time. So this individual was followed for 30 months and they're still staying quite flat. There is one individual here who's kind of progressed quite rapidly and then increased again, but overall lots of variability and little sensitivity to disease progression, to measure sort of disease progression. We can take this data and very simply, I'll say, understand what we expect the change from baseline to be on this endpoint at 1 year and 2 years. Use those expectations then to say, okay, how many subjects would we need if we wanted 80% power, assuming that we had sort of a 50% reduction in the decline. So if you were expected to decline, say, 2 units, then you would decline instead one unit under that treatment effect. And what we saw is that we would need about 1,200 individuals for a 1-year study or 300 individuals for a 2-year study if we use this endpoint. These were not realistic estimates of how many individuals we could get whatsoever for GNA myopathy. A more realistic estimate would be about 50 to 80 individuals in the study to realistically be able to enroll. Power for that type of study was between 10 to 30%. So very small using this highly variable endpoint. So it's very clear that we need something better than this. Alternative, as you can see where we're going here, is to use this QMA, the measured muscle strength, on several muscle groups. And you'll see why I'm showing this exact one in a second. This endpoint that was proposed was sort of a composite upper extremity strength. So average together or sum together the strength you have on the QMA for the upper extremities. And you can see that because people are probably at very different stages of the disease, you have sort of clusters here, and you can see how they progress, but still pretty variable across the course of the individuals in the natural history study. And if we use this to understand power of, say, a study of size 80 who are followed for 1 year, we can expect the power of that sort of study to be about 20%. So very low power if we use this endpoint and follow individuals for 1 year. So why am I telling you about this? Well, this actually was the study that was run. Ultragenics ran a study of this size, 80 subjects followed for actually a little bit less than a year, and this was their endpoint. And just from our natural history data set, we were able to predict that the power of their study was very low. This was a really underpowered study for the endpoint in the analysis that they proposed. And of course, their study was not successful in meeting their primary endpoint, which, if you take nothing else from today, you should take away to truly understand, have realistic estimates of your power, especially when dealing with small sample size. Because you do not want to be in this situation where you have not essentially learned anything from your trial because you are underpowered. This is truly a failed trial where we were not able to discern at all if this treatment truly does work or not, which is an unfortunate situation to be in, especially in the rare disease setting and when there are no known treatments available. So again, we're at about the same situation we were for the Diane group. With the proposed study, we have about 20% power. So what are we going to do? What innovations can we come up with here? What ways can we increase power, given that we know we can't just increase the sample size? That's not something that is realistically going to be enrolled any more than 80 subjects in this trial. So again, our goal was to understand sort of muscle decay or natural progression of the disease, not in terms of sort of composite strength where you sum up all the muscles, but systematically how the individual's muscles progress over time. And time meaning this sort of unknown disease stage. So this was our picture that we sort of drew up from the beginning to our goal to be able to create this picture where dorsiflex sort of ankle sort of starts progressing at this point. This is how quickly it does. Then knee flex, grip, and hip extension. This is what the data actually looks like, the raw data for individuals. So subject A here, red is dorsiflexion. They're completely progressed on dorsiflexion. Purple is elbow flexion. You can see they're actively progressing more on grip, elbow flexion, and maybe shoulder abduction. And they were about 30 years old at the time of the study. Subject B is kind of flat on the upper extremities, but actively progressing sort of on ankle dorsiflexion, and also at about 30 years old. So you can already start to see that chronological age is not a great predictor of disease stage. These subjects, although the same age at baseline, very different disease states. Subject C, about 36 years old, totally progressed on the knee flexion and ankle dorsiflexion and actively progressing on the upper extremities. And here's subject D, who is actually performing quite well, above average on all muscles except for dorsiflexion. So you can see another thing here is that we'll have to account for, as we did in the Diane study, that some individuals are just stronger on average than others. And we need to account for that when summarizing our natural history. This is a picture of how I took the dots for every individual, same ones I have on here, A, B, C, and D, but also all the other individuals in our natural history study, plotted them against their chronological age, the muscle strength for each endpoint. And if you don't see anything here, that's okay, because we did not either. What this picture is showing is that there's not a clear decay pattern as a function of chronological age for most of these muscle groups. Maybe the most clear pattern is sort of in knee flexion, sort of a decay pattern here. D is certainly an outlier in that they're 50 years old and still have most of it. I am stuck again. Sorry about this. Freezing up. Okay, so really, and I think I'll skip over these slides quite quickly, but this was similar to the Diane case. We developed a disease progression model. This is, again, just a monotonic model to understand how each muscle will progress over time as a function of this sort of latent disease age. I'm going to skip over the specifics here and just kind of show you what this looks like. So essentially what we're doing is, this is a very slowly progressive disease. The course of this disease, we're talking about 40, 50, 60 years from healthy to ultimately being in a wheelchair. And so we only have very narrow snapshots of this disease from each patient. So essentially what we want to be able to do is take these narrow snapshots. These are very narrow pieces of the puzzle, the overall picture of disease progression, place them where we think they go in the puzzle. That's quote unquote disease age or disease stage. Patient D here we think is probably a lot less progressed than the others based on what we're seeing in the other muscle groups, whereas patient A is probably one of the most progressed. Maybe their disease age is around 10, 15. So we take all these snapshots, we put them together in the overall bigger picture puzzle of how this disease progresses. We do this for everybody, so I've moved them left and right where we think they are in the disease. And the model estimates this. I don't just move this by hand. And then we can estimate sort of lines or average rates of progression as a function of disease age, sort of our goal plot that we had from the beginning. And just very quickly here, I want to note that the model itself, we're anchoring and sort of calling disease age 0, essentially when 50% of the max muscle strength was observed for knee flexion. So that's disease age 0. This can be generalized to anything, but we just wanted you to have the individual to have some notion of, okay, disease age 0 means when knee flexion is at 50%. Then we can sort of order the muscles. We can see that ankle dorsiflexion, the ankle muscle, progresses to its 50% about 7 years before knee flexion. Grip progresses about 10 years after, shoulder abduction about 2 years after, and elbow flexion about 9 years after knee flexion. Knee extension stays quite flat across the course of the disease, and this had face validity to it. This GNA myopathy actually originally was known as the quadriceps bearing disorder. So there was some, when we showed this to the clinicians, there was some face validity to the fact that knee extension stayed relatively flat across time. Again, this is the overall picture of each muscle group and the expected decline and the variability around that as a function of disease stage. And again, just another picture of that, only now subject specific. So what we can do then is for each subject, we know their disease age. Subject A, we think it's 17 years since when their knee flex was at 50%. We can draw where we think they'll be sort of over the next 10 years on each of these muscle groups if they follow natural progression, or if they were on placebo, where would they be for each of these muscle groups? You can see for subject B, we think they are 8 years before when their knee flex gets to 50%. And you can see where we believe or predict they'll go over this sort of next 10 years. So subject or patient-specific predictions. And I'll move through this a little bit faster since we're coming up on time, but I also wanted to note that in this modeling that we did, the only endpoint that we used was the QMA, the muscle strength. And we used that muscle strength of everyone on 6 muscles to get sort of an estimated unobserved disease stage, or what we call disease age, for each person. We then wanted to see how this disease age, estimated only from muscle strength, correlated with other functional measures such as climbing stairs, walking, so on and so forth. So what we've plotted in all of these plots are a subject's estimated disease stage from the QMA data versus what we're also measuring, sort of different functional measures. Here's climbing stairs. And what we saw is now we can have a whole picture of the disease. We understand the whole disease spectrum, where individuals climb stairs slow with the intermittent use of a handrail, probably up until about disease age 0. Then for the next about 25 years, they're probably depending on the handrail more and more for climbing the stairs. Then they'll require additional support and almost unable to about 30, 35 years after when knee flex was at 50%. And you can see this sort of heat map, or how quickly these different functional measures progress as a function of disease stage across the board here. And again, this is just to reiterate this model, and the natural history data allows us to get a big picture of what we expect this disease to look like at different stages. And so again, disease age 0, this is when knee flex was at 50%. Knee flex is back here. This is essentially this muscle. And so this one has started to decline. Dorsiflex has started to decline. And at this point, shoulder abduction is started to decline. Grip, knee extension, as well as shoulder elbow flexion, all are remaining relatively normal. And what does this relate to, given the data we just saw? Well, this person likely has intermittent use of a handrail when climbing stairs, mild unsteadiness when walking, and using substitute motions when standing from sitting. So we have this overall summary of what we expect the disease to look like at different stages. So again, just as we did before, we can use these summaries to understand, sort of do virtual patient level simulations as we did in the Diane trial, understand power of proposed designs. We did that earlier and we saw that under sort of more traditional endpoints, if we just look at sort of composite strength endpoints, we would be majorly underpowered. So what we did, and again, I don't want to spend too much time on the specific analysis, but just to show you that being more innovative in terms of how you actually use the data can lead to major increases in power. So essentially what we did is took our disease progression model, and again, I don't want to go into the statistical details here too much, and introduced a treatment effect parameter. So if we enrolled placebo subjects as well as treated subjects, we could estimate the common slowing in the rate of progression across all the muscle groups for individuals treated versus those not, or at time points post-treatment versus the time points before you had treatment. And so what this might look like is that if you're expected to progress like this, you're treated at this point, we have, say, what we call gamma. This is essentially 1 minus a % slowing. So if you're expected under treatment to have a 40% slowing in progression, you would instead look like this dotted line. So big difference then between what you would look like under natural progression versus 40% slowing. Whereas if the treatment was given later on in the disease, or if you looked only at a muscle that was already progressed, say dorsiflexion, you would expect a very small difference between a perfect cure and natural progression. So this shows multiple things, that with this idea of sort of a percent slowing and progression, we need to be able to look at muscles that are actively progressing. We don't want to be downweighting any signal because we're looking at muscles that weren't expected to progress. Also, that we want to be using all the muscles available, incorporate all of them into the estimate of the treatment. And this slide here just shows sort of that what does this treatment effect mean? What does a 50% slowing actually mean? I'll go quickly through this slide, but just to show that this is truly a slowing in time. So it's essentially, if you have a 50% slowing in the reduction across all the muscle groups, this is the same as a 50% slowing in time. So where you were expected to be 10 years from now under this type of treatment, it would take you 20 years to be there. You would have 10 more years sort of in that current state before you got there. So it truly is sort of a slowing in time in terms of the disease. And here, just in summary, for our current proposed design in GNA Myopathy, and this is actually planned to start enrolling pretty quickly in the summer now, we enrolled about 50 individuals. This is our current plan design, 2-to-1 treatment versus control. Follow all subjects for 2 years. And I show power here for following everyone just to 2 years versus that idea of extended follow-up. So the first patient enrolled, continuing following them until the last person gets to 2 years. And our primary analysis uses this disease modification model. We look at different treatment effects. Here we're powering for about a 50% slowing in the rate of progression. And here you can see with our proposed design, our new proposed analysis, we have about 89% power if we're not taking into consideration loss to follow-up. We have about 10% annual rate loss to follow-up. We're down to about 82% power. However, if we add back in extended follow-up, that some are followed for 2.5 to 3 years, we are back up at about 89%. So again, as I promised, the GNE story is quite similar to the Diane story, and that our natural history study and the data from that allowed us to have more realistic estimates of power. We could see that the traditional design, or even a trial that was recently ran, had about 21% power. So we need, this is missing here, but there's a desperate need for better endpoints, better analysis methods. And in doing so, we were able to increase the power from 21 to 80. And I'll just finish then with sort of one word of caution for any statisticians who might be listening. It's necessary, so with a more sort of innovative analysis, sometimes those come with more assumptions. In particular, for these slowing in the rate of progression type analyses, we're assuming that the treatment effect is proportional over time. You just want to make sure you understand any sort of implicit or explicit assumptions that are going into the analysis method that you're using. If you're talking to a statistician, if you are a statistician, as statisticians, we can come up with very complex models and analysis methods. We want to make sure that we're continuing to talk with clinicians and we continue to have good communication to make sure that what we're proposing as an analysis method, if it's different from the more traditional and standard approach, is clinically meaningful, is clinically relevant, and that the assumptions that we're making are reasonable assumptions. So just sort of a word of caution if you're thinking about more innovative approaches to study design and to analysis methods. I'll end here just with a slide showing the references. So the first two are for the Diane trial. One is about the design and the other is about the analysis method that we use. And the latter is about the GNA Myopathy, the analysis method that we use. And I have about 5 minutes. So I'll take any questions that you might have, either in the chat window or if you want to go off mute.
I have unmuted you all, so feel free to ask your questions or use the chat box. There's no questions, comments?
Well, if there is any interest or questions that come up, if you wanted to review those references, I can certainly provide the PDFs for those to Joy, and she can circulate those if anyone's interested in looking at that. If there are questions that come up, you can feel free to get in touch with me, and I'll be happy to answer those.
Melanie, can you send me your slides to post to our website for those who
Sure.
missed it today? Would that be all right? Okay.
Yeah, I'll send around the slides and the references.
Awesome. We got a couple of thank yous in the chat box, so I really appreciate your time and your presentation today. And again, if anyone has a question later on, feel free to send them to me and I can forward them on to Dr. Quintana. So thank you very much, everyone, and we will see you next week at the course, or the next webinar will be September 10th. So thank you. Take care.
Great. Thank you, guys.